My name is Tom Grabowski. I'm a neurologist. I have two hats that are relevant here. I direct the Alzheimer's Disease Research Center at University of Washington, and I'm very active clinically in this space as well. I'm here to talk about a research framework for thinking about Alzheimer's disease and related dementias. That practically means I'll talk a lot about biomarkers and how they're used. But I also would like to create some perspective on what advantages those may have beyond simply certifying diagnosis for these groups. Everybody knows that the prevalence of Alzheimer's disease is greatly increasing. We're at 5.8 million cases in the United States now, projected to double in the next 20 years because of the aging of the population. This prevalence increase obscures also what seems to be a slight fall off in incidence in developed societies because we think of systematic control of hypertension and education. And I'll come back to these factors a little bit later because this idea of cognitive reserve is an important one. But we've made headway on mortality for many major diseases, but not Alzheimer's disease. And so the number of cases of death due to Alzheimer's disease is on the rise, and this is arguably the biomedical challenge of our time. Can everybody hear me okay? Yes, good. Okay, so here's what I want to talk about. I'm going to start at the beginning, and I really want to emphasize the importance of the distinction of thinking about the syndromic or clinical diagnosis separately from the etiologic or pathologic diagnosis. We'll talk about what we mean when we talk about ADRD, biomarkers, and so forth. So I'll come back to all that. So ADRD, everybody should know, this is Alzheimer's disease and related dementias. This is sort of a political term, okay? You can read the 4 most common causes of dementia, okay? The NIH has formally defined ADRD to be Alzheimer's disease, vascular dementia, Lewy body dementia, and frontotemporal lobar degeneration, okay? Privileged with respect to funding situation right now. ADRD itself is not a diagnosis, it's a collection of entities. Okay. So you might write in your grant, we're studying ADRD, but at some point you need to be specific about which diagnoses you're actually interested in. So to start with, like I said at the beginning, dementia. This is the DSM-5 criteria for major neurocognitive disorder, which is the term in the DSM that replaces dementia. And the important things are substantial decline in one or more domains, and domains are listed here. And this is something that is there's concern brought to attention either by the individual, by someone who knows them well, or the clinician. So there has to be a sense that there's been a decline. And then you have to be able to document a decline in performance, and it's typically 2 or more standard deviations below a norm. We've heard this morning that that's problematic in some situations in the populations we're talking about. And then sufficient to interfere with independence, that is requiring more than minimal assistance with instrumental activities of daily living. And this is the sort of parallel definition for minor neurocognitive disorder, otherwise known as mild cognitive impairment, where there's, instead of marked decline, there's modest cognitive decline in 1 or more domains, typically memory, but not always. 1 to 2 standard deviations of decline, and insufficient decline to interfere with independence. Cross-sectionally, especially in a population-based study, this is a slippery diagnosis. A substantial number of persons that would be thought to have mild cognitive impairment cross-sectionally who didn't present themselves with a complaint to the clinic, but you just screening them, something like 30% or even 50% will revert to normal cognition on the next measurement. Okay, so you might have mild impairment for lots of reasons. How well you slept the night before, what else is going on in your life, and so forth. So you have to be careful whether this diagnosis is ascertained in a screening situation or if this is ascertained in a clinic. Okay, it makes a difference that people make the effort to get to the clinic. Does that make sense? So my point here is that these are clinical terms. They describe the state of cognition and everyday function, and they don't make any reference to pathology. In fact, there are many things that can cause these syndromes. Some of them are not degenerative. For example, we see patients in the clinic whose primary problem is major depression, who meet all the criteria for major neurocognitive disorder. Okay? So you don't have to have anything structurally the matter necessarily in the brain to have this sort of clinical definition. Okay, so that's dementia and mild cognitive impairment. What is Alzheimer's disease then? So Alzheimer's disease is, if you go back to the beginning, Alzheimer's disease is what Dr. Alzheimer saw in the brain under the microscope in his patient. So you see two pathologic hallmarks. You see this extracellular accumulation of amyloid protein. That's called an amyloid plaque, made mostly of a protein called amyloid beta. You know, it's surrounded by sort of an inflammatory and reaction, and a whole other bunch of other things go on. But if you don't have amyloid accumulating in the brain, you can't call it Alzheimer's disease. That's the sort of hallmark of the disease. And then there's the second finding called the neurofibrillary tangle. So this is the accumulation inside the nerve cell of another protein called tau. Actually, it's a phosphorylated version of tau. We think that this tau accumulation is marking the degenerative change in the disease. It is marking the dysfunctional systems in the brain. So you have plaques and tangles, and if you have plaques and tangles, this is pathologically Alzheimer's disease. Okay, so Alzheimer's disease is a degenerative disease of the brain with distinctive histopathology, and we just talked about what that means, specifically characterized by tissue loss accompanied by neuritic amyloid plaques and neurofibrillary tangles in the brain. So in contrast to the dementia situation, Alzheimer's disease is a pathological term. It describes a disease state of the brain typically leading to dementia, but not everybody with Alzheimer's disease has dementia or necessarily ever develops dementia, and we'll talk about that. There are milder and preclinical manifestations of it. So it seems basic, but you'll save yourself a world of hurt to maintain this distinction between the clinical diagnosis and the pathologic diagnosis. The statistics I talked about at the very beginning of the talk, 5.8 million Americans, we're talking about Alzheimer's dementia, okay? Not mild cognitive impairment or preclinical disease. If you really want to know how many people have preclinical and MCI and dementia, multiply those numbers by 3, okay? That's what the true burden of the pathology is in the population. CPT codes that we use for diagnosis in the clinic, when we use codes that call for Alzheimer's disease, they mean Alzheimer's disease dementia. In fact, we have a lot of trouble really coding up mild cognitive impairment, probably due to Alzheimer's disease. That's kind of hard to code. Okay, so it's sort of built into the system, this confusion between dementia and Alzheimer's disease. And I'd say it's fair that there's both public and professional confusion around this. So it's not a trivial point. Do you agree with me, Jim? Oh, yeah. So keep it straight. Cognitive diagnosis versus causal diagnosis. Dementia does not always mean Alzheimer's, and Alzheimer's does not always mean dementia. Yeah.
So just for
Deidre.
clarification,
Yeah.
often you see the Alzheimer's pathology and no symptoms.
So how often do you see Alzheimer's pathology and no symptoms? Well, we have the advantage at the University of Washington of working closely with the ACT study. So ACT is is a population-based study of dementia risk, maintaining a random sample of the Kaiser clientele. And they have an active autopsy program. So we see lots of people from ACT come to autopsy, and it is not uncommon to see people with even fairly advanced Alzheimer pathology at post who were not demented in life. So we see it fairly commonly. I'll come back to that, it's an important point, but the relationship between the severity of cognitive symptoms and the severity of the pathology is not firm. It's modifiable, for one thing, by lifestyle, and probably by genetics. But we see people with relatively high disease burdens in the pathology sense who don't have a lot of symptoms. We think they eventually will if they were to live long enough. Hope that answers your question. We'll come back to it. Okay. All right, so this is the way I think about it. You have a set of processes that gang up to cause brain atrophy. So aging being the cardinal risk factor, but other risk factors, for example, diabetes, disease processes, Alzheimer's disease, pathophysiology, vascular brain injury, other diseases that we aren't talking a lot about today, like Lewy body disease. And there's a genetic component to this. And you develop these pathological changes in the brain. Those, in turn, affect the function of neural circuitry, and the outcome of that is cognitive impairment. Okay? So you have a clinical or a cognitive diagnosis, which is pertaining to the cognitive trouble. And I'm going to skip that. And you have an etiologic or causal diagnosis that pertains to what you would see if you could look under the microscope. Okay? Ideally, in our clinic, you would get both diagnoses. For example, amnestic mild cognitive impairment, probably due to Alzheimer's disease. And there are factors, clinical factors, that make this, the consequences of this brain change worse with respect to cognition. So there are, if you have a lot of medical comorbidity, let's say depression, let's say uncontrolled diabetes, medications can adversely affect the efficiency of the system and lead to more cognitive symptoms, sleep disruption, substance abuse, the list goes on. There also are some good guys. There are some things that help you resist degeneration, good vascular health, for example, genetic factors that we don't fully understand yet. And then there's this very important piece. You heard Mike refer to cognitive reserve. We sometimes talk about resilience or functional resilience, and this has to do with the brain being robust in some way to the burden of pathology. There's some sense in which you can build a stronger brain. We don't know whether that means you have more synapses, whether your frontal lobes can compensate better for trouble posteriorly, but there's a phenomenon of resilience, and I'll talk more about that in a minute. Okay, so besides Alzheimer's disease, what else causes dementia? We've ticked a few of these off so far: vascular brain injury, Lewy body disease, frontotemporal degeneration. Those are the three, in addition to Alzheimer's disease, that NIH has officially designated as ADRD. Okay. But also depression, as we mentioned. You may have serious metabolic disorders, severe hypothyroidism, for example, vitamin B12 deficiency. Other things classically can cause at least a somewhat treatable or reversible situation of dementia. Structural disruption in the brain for other reasons: hydrocephalus, brain tumors, subdural hemorrhages. The original reason for doing any imaging in a workup for cognitive impairment was to detect these kinds of things, these structural, maybe surgically approachable problems, metabolic disorders you could correct. In the day, Alzheimer's disease was the diagnosis of exclusion after you looked for these things. It's not quite that bleak anymore diagnostically. And now to reinforce a point that Mike made a little while ago, it is very common to have more than one degenerative or pathologic process at the same time. And the older the individual that's affected, in fact, the more common this situation is. This is a diagram that's taken from a paper that Tom Montine's group wrote using the ACT study that I mentioned a little while ago. And they looked at 119 patients with dementia came to autopsy. And the way this graph works is every line here is one person, like that red stripe there, that's one person. And 3 different pathologic entities are recorded here. Alzheimer's disease changes, sort of microscopic changes in blue, Lewy body changes in green, and vascular brain injury in red, and they're stacked up. Each of those has their own severity scale, and there's just summed to give the height of the column. And they're sort of ordered from least to most burdened by pathology. And you can see basically in 119 patients with dementia, virtually everybody has some combination of these changes. The second thing you see is there's lots of blue and lots of red. Lots of people have Alzheimer's and vascular brain injury. And the population attributable risk for dementia in this study was 45% for Alzheimer's disease, 33% for microscopic vascular brain injury, 10% for Lewy body, and 12% unexplained by those 3. A little footnote here, when we're talking about vascular brain injury, we're really, in this study, pathology study, based on autopsy, we're talking about cortical microinfarcts, small infarcts in the cerebral cortex that are basically not visible on MRI scans. Okay? So we have a sort of a disconnect in the field between what we can see on imaging in terms of vascular pathology and what we can see on autopsy with respect to vascular pathology. Cortical microinfarcts are not visible on imaging, but are visible at autopsy. On the flip side, what we see in imaging are these subcortical white matter hyperintensities that correlate not so well with cognitive impairment. They're sort of markers of cerebrovascular disease, but they're not very strongly related to the degree of cognitive impairment. Okay. So we've talked about understanding dementia versus Alzheimer's disease, and we've talked about ADRD, and now we'll talk about biomarkers. So really, we've already introduced this topic. So, we've already talked about 2 markers of Alzheimer's disease, right? Amyloid beta and phosphorylated tau tangles. These are characteristics that signify the disease processes. They may or may not be directly related to the actual processes causing the dementia. In fact, we really don't know fundamentally what are the really true ultimate processes leading to neurodegeneration. We think amyloid has something to do with it, but as everybody in the room is probably well aware, all of the therapeutic attempts we've made to manipulate the amyloid axis have been unsuccessful to date. So there's more to the story. For now, we're really talking about using these proteinopathies of Alzheimer's disease as markers. This is what stamps it as Alzheimer's disease, whatever is really the matter. Does that make sense? All right. Now, these markers are kind of distributed unevenly through the brain. That's one thing. On the top tier of this is a real venerable study at this point. This is the late 80s from Brad Hyman and Steve Arnold when they were at Iowa. Just look at the top tier, and this is a cross-sectional abundance of neurofibrillary tangles in the brain in patients with Alzheimer's dementia. And it's a heat map, so the hotter colors show more tangles, and the colder colors show fewer tangles. And you can see the hottest area is here in the medial temporal lobe. Next is basically the rest of the temporal lobe. And on the blue end of the spectrum, you have the areas that are relatively spared. And the neurologists recognize immediately that this is your primary motor, primary sensory, primary visual, and primary auditory regions, the areas that are most directly connected with sensory motor function. So there's a pattern of severe involvement of medial temporal lobe and association regions of the cortex, and a relative sparing of the sensory motor primary regions. And that cross-sectional relationship sort of holds up longitudinally too. And this is a more seminal work that was done by a husband and wife neuropathology team, Heiko and Eva Brock, so Brock staging of Alzheimer's disease. And we now standardly talk about 6 progressively more severe stages of neurofibrillary tangles in the brain that begin in the medial temporal lobe, gradually move out into the other limbic areas and the inferior temporal lobe, and then eventually affect the isocortex of the brain sort of widely, but relatively sparing the sensory motor regions. Okay. So, and that's one reason that's important is that those that Brock staging has a fairly satisfying relationship to what we see clinically. So when we have this medial temporal involvement, it sort of corresponds to a clinical phase dominated by memory loss. So there's early and salient memory impairment. As the temporal and the rest of the association isocortex is involved, then you have broader cognitive loss, which you would map onto dementia. And then these areas that are spared, it's really classic in an Alzheimer patient to have, virtual sparing of elementary sensory motor function. You can watch someone from across the street, have no idea that they have this severe neurodegenerative disease. You can talk to them at a party and maybe not have an idea either. So that's one of the reasons we think that this sort of satisfying relationship between the distribution of the tangles and the cognitive status, as we know it from other sort of brain behavior relation studies, makes us understand that it's really the tau that is marking these dysfunctional systems in Alzheimer's disease. Okay, so that helps us think about stages of Alzheimer's disease. And remember, in the popular mind, Alzheimer's disease and dementia are more or less equated. There's this 8 or 10 years, from time of diagnosis to demise, that is the dementia phase. But this is really the culmination of a process that's been going on for many years before this, probably 20 years or more. There's a stage of mild cognitive impairment, and before that, a truly pre-symptomatic latent phase of disease that we think might be a good 15 years or so. So making a diagnosis out here, and why would you want to do that? Well, for research purposes, we're looking at this enormous time window as an opportunity to intervene and slow the process down before cognitive impairment happens. So this, suddenly makes prevention seem like a realistic strategy. Okay, but to get diagnosis here, you're going to need ways to detect disease, and that's where the biomarkers come in. So biomarkers are measurable characteristics signifying disease. In the realm of Alzheimer's disease right now, you have 2 sources of markers: imaging tests and spinal fluid protein levels. I'm going to show you some of the imaging ones, even though they're maybe not the technology you're going to be exposed to, just for reasons of expense and accessibility, but they make a few points. So it is now possible to make PET images of the distribution of amyloid protein in the brain. So we give a radioactive tracer that seeks out and attaches to amyloid protein. And I'm showing on the top tier what these images look like. Here are the structural MRI images from the same individuals. And what you should see in somebody that's not affected is you should see the tracer gets taken up into the white matter of the brain. This is sort of a non-specific effect. It doesn't it happens independent of amyloid. And so you can see the sort of the gray-white distinction in these scans. You can almost see a skeleton of white matter marked by the darker parts of the image. If you look at the two right-sided images, you'll see that you lose that nice distinction, and everything looks, it's almost like a ground glass appearance, and you obscure the distinction between the gray matter and the white matter, and that's because you've got a lot of amyloid now accumulated in the cortex, and it's giving that homogeneous appearance. So those are amyloid PET scans, available clinically only in very selected circumstances and pretty expensive. This is the latest PET tracer that's available. This is a tracer that seeks out phosphorylated tau in neurofibrillary tangles, so-called tau PET scan. And this is what a normal scan looks like, and this is what an individual with Alzheimer's disease, this person has a mini mental state score of 18, so this would be a MoCA score of around 14, showing a distribution of neurofibrillary tangles that's fairly advanced. We have learned that these, and I should mention, both the amyloid and the tau species can also be measured directly in the spinal fluid instead of a PET scan. And we have learned that these markers appear in sort of a canonical temporal sequence. So let me unpack this diagram for you, because this is one I know in my sleep. When I go to the Alzheimer's meeting, this image is shown at least 20 times a day. It's work that comes out of the Alzheimer's Disease Neuroimaging Initiative. Clifford Jack has spearheaded some of this. But what I'm showing on X is a progressively severe clinical stage of disease. So dementia, mild cognitive impairment, and the yellow zone is the latent or pre-symptomatic epoch. And then on Y is how often and to what degree a given biomarker test is abnormal. Okay, and so if you look at cognition, if you want to think of measuring cognition, by definition, cognition isn't abnormal until you get to mild cognitive impairment stage here. If you look at MRI scans looking at brain atrophy, it's the orange curve here. You can see atrophy occurring especially in the hippocampus in advance of the mild cognitive impairment phase. But if you want to find out how often is it, so where's the 50% line where it's at least half the time abnormal, it's solidly in the MCI stage. And then you have this other collection of curves here on the left side that are the spinal fluid amyloid, the amyloid PET, and the spinal fluid tau. And since tau PET has come along, it would be somewhere near the blue curve here. These measurements are abnormal most of the time before there are any symptoms of degeneration. Okay. Yeah.
I have a question about this graph.
Yeah.
Is this in patients longitudinally that have been marched along? Because I'm impressed between the disconnect between the biomarkers and the impairment. So are these groups of people, or is this something you've demonstrated in individuals?
For the most part, this is cross-sectional data. For the most part, I mean, the tau PET scans, for example, are just, we've only had longitudinal tau for a couple years. I would say most of this was done cross-sectionally. Yeah.
Right. So it's not like
Right.
and then they march along and they get these different markers showing up at certain times?
For the most part, no. Yeah. Okay. So that's what I want to say about introducing biomarkers. So now let's talk about sort of the heart of the talk here. So the NIA Alzheimer's Association Research Framework, which is now proposed a very biological definition of Alzheimer's disease. And this is affectionately known as ATN, where A stands for amyloid, T stands for tau, and N for neurodegeneration. And basically looking for a binary decision on each of these three axes. Okay, is the individual amyloid positive or negative, tau positive or negative, and neurodegeneration positive or negative? And the modalities that are coming into play here are spinal fluid and PET measures of amyloid, spinal fluid and PET measures of tau, and MRI and PET measures and spinal fluid measures of neurodegeneration. Okay. In this framework, it's possible to classify everyone in a study according to whether they're positive or negative for AT and N. So just for example, from the paper here, on the left you have someone whose amyloid scan is positive here on the top row, whose tau scan is positive here in the lower left corner, and who shows hippocampal and cortical atrophy on MRI, therefore A positive, T positive, N positive. And on the right, someone whose amyloid scan is positive on the top tier, whose tau scan is negative on the middle tier, and who does not have atrophy on the structural MRI scan, and therefore is A positive, T negative, N negative. Okay. So the ATN framework then looks at all these combinations and assigns participants to particular diagnostic categories. So look at the red set of rows here. And what these all have in common is A is positive, amyloid positive. And this, as I mentioned earlier, the amyloid is the sort of pathognomonic feature of Alzheimer's disease. And this defines the continuum of Alzheimer's disease in this research framework. So if you have a positive amyloid marker, you have Alzheimer's pathologic change. If you also have a positive tau marker, then according to this framework, you have Alzheimer's disease, full stop. Okay? Alzheimer's disease, regardless of what your cognitive state is. Could be normal, could be mild cognitive impairment, could be dementia. So that's the way this works. And if your amyloid marker is negative, then you have non-Alzheimer's disease pathologic change, whether or not your tau marker is positive or negative, and whether or not you have neurodegeneration happening. Yeah.
Is there some sort of cutoff on the scans when you look at amyloid, or is it just present?
Okay, that's a good question. So Maureen wants to know how do you threshold these scans? It's interesting that by the time people present with mild cognitive impairment, it's not a close call on an amyloid scan. Amyloid scan is pretty much maximally positively abnormal if it's going to be abnormal already. That said, there is a numeric cutoff for this, and it comes into play, especially when you're looking at pre-symptomatic epoch. But at mild cognitive impairment, it's usually not close. It's interesting. The amyloid accumulates early. I'll come to it in a minute. The curve for amyloid positivity and the curve for dementia due to Alzheimer's disease are parallel each other, but they're 15 years separated. And we think amyloid scans are turning positive on average about 15 years before diagnosis. Cross-sectional data, yeah. So then if you look at, then I've just sort of now got columns here on the cognitive axis. So cognitively unimpaired, mild cognitively impaired, and dementia. And in this research framework, let's say you have mild cognitive impairment, you're A+, T+, N-. This is Alzheimer's disease with mild cognitive impairment, for example. But it's possible to be in this cell where you have preclinical Alzheimer's pathologic change, even though you're cognitively unimpaired, or preclinical Alzheimer's disease if you have a tau marker that's positive, even though you're cognitively unimpaired. So, so this is what's been sort of rolled out over the last 2 or 3 years in the kind of national meetings for Alzheimer's disease. This has undergone a lot of refinement and a lot of feedback has been given. I think it's fair to say there's been quite a bit of pushback around this. A lot of it around the semantics of what you mean by disease. We made this point earlier. There are a lot of people that are A positive, T positive at autopsy. So the other way to do this is just to look, in the tissue. But we're not demented in life. So did we say they had Alzheimer's disease? And should asymptomatic persons in general be diagnosed as having Alzheimer's disease? It's obviously a stigmatizing term. So those are some of the issues. The group that spearheaded this really tried to drive home the idea that this is not for clinical work. This is not something the clinic is ready for. But is it really feasible in the information age to keep a distinction between a clinical and a research framework? I mean, everybody's coming in with reading something on the internet these days.
So, Tom, I
Yeah.
think there's another area of pushback, and that is that the kind of testing you need to do to classify these people is typically not available to minority populations. So
Right.
that they're already being excluded in just regular research where we're even just doing a screening test. Then when you start talking about PET scans and these more extensive workups, it's going to reduce the number of minorities, particularly Native people, to like virtually zero.
Yeah.
So that's another piece of the
Yeah, I think that's really important. And it's, it's unfortunate that these markers are as inaccessible as they are. I mean, right now, it's a spinal tap, which isn't, I mean, we neurologists know that isn't a huge deal, but in the popular mind, it's a huge deal. And PET scans, which require a cyclotron and tracers and many thousands of dollars per participant to get. So it's not practical. It's not practical in any group almost to get large numbers of these, let alone an underrepresented group.
I think
Yeah.
the other part that I've heard a lot of talk about is, I know you have an interest in this, is there's a lot of conversation about resilience. So people who have these markers that don't have Alzheimer's. But when we talk about resilience in Native communities, that's not what we're talking about. And I think
Yeah, and I'll have a little more to say about resilience in a minute. Yeah.
Just the whole sort of classification system doesn't take into account a lot of cultural aspects and logistical aspects of diagnosis.
Yeah, I mean, I think it's a great point, and we should have some more discussion. On the other hand, the opposite of pushback, these are the reasons that this probably is progress. ATN is defining specific biological states. I mean, that's objective and targetable by interventions. It offers a principled way to analyze preclinical Alzheimer's disease. And it also brings these ideas of resistance and resilience to attention and into a sort of scientifically approachable framework. So I think, in a way, maybe especially for this population, these would be really nice to have. I think the conundrum is the expense. But on the other hand, we think we're only 2 or 3 years away from having a reasonable plasma amyloid test, for example. And those are looking really good in terms of predictive value negative, so there would be great screening tests. And so, you know, if you just imagine that you didn't need spinal fluid, but you needed a blood test, it might change the way you think about this. Okay, so here's I described this a little while ago. The red curve is the incidence of probable Alzheimer dementia. The blue curve is the rate of positivity of an amyloid PET scan. And the lag between the two is about 15 years. We think that at age 70, about 20 or 25% of individuals will be amyloid positive, just to give you a sense of the scale of that in the population. So that's a lot of people. Okay, so preclinical AD is common. The biomarkers indicate disease processes are clinically latent years in advance of symptoms. We talked about amyloid PET scans leading clinical disease by 15 years, already maximally abnormal at the stage of mild cognitive impairment. And, you know, there's probably, you know, if your frame is on dementia, that's one thing, but the real extent of the disease is in the population is significantly larger, and there's probably 2 individuals that are pre-demential for everyone in dementia. Okay, now to the point that Deidre was talking about. So there is this phenomenon of variable susceptibility, which we can usefully divide into 2 categories. There's very little like global agreement about these terms, so I'm going to define them. This idea of biological resistance to Alzheimer's disease, that would be that you're developing little or no pathology despite your high risk. So for example, an APOE4 homozygote, or someone with a genetically driven propensity for Alzheimer's disease who's nevertheless not developing the disease. Okay, so that's resistance. And then there's this more physiological or functional resilience, which is you have mild or no cognitive impairment despite the pathologic load. Another term that has been used that has some other connotations to it is this term of cognitive reserve for this. So one's a biological phenomenon, and one is more a functional or physiological phenomenon. So I said a little while ago that you can roughly divide Alzheimer's disease into this pre-symptomatic, mild cognitively, and demented phase, correlating more or less with Braak stages. But in reality, this relationship gets kind of slanted like that. And there are factors that can help you, I like to use the term lean in, help you lean into this disease so that you might have Braak stage 5, but instead of having dementia, you have mild cognitive impairment, for example. Or maybe even exceptionally, you might have Braak stage 5 and not have even mild cognitive impairment. And some of the factors that have been implicated are education and your sort of integrated lifestyle habits, through midlife. How cognitively active are you? How aerobically active are you? How socially connected are you? Have all been shown to factor into this. And then there's the flip side of this. There are factors that can drag you back into a situation where you should be pre-symptomatic, but in fact you have cognitive impairment. And these have a lot to do with comorbidities, especially cerebrovascular disease. That was essentially the finding in the Nunn study that Mike mentioned earlier, where you have this synergism between vascular and Alzheimer pathology in the brain. So just to talk a little bit about this resilience, you can kind of just see this even in even in our clinic data. So what I'm showing you here are, okay, so what I did, I have to explain this. We see maybe 1,000 new patients a year in our memory clinic. Many of them have brain scans. We're able to amalgamate these clinical data and analyze them sort of in an anonymized repository. And what I did was to ask to do it's actually sort of a regression analysis. We're trying to predict someone's MoCA score, their cognitive screening score, from their amount of brain atrophy and their age. And the way you operationalize the brain atrophy is how big is the brain in relationship to the cavity in the skull that it fits in, because in development you fill the skull, and if it's not filling it, there's been some atrophy. And so you do that and you get a residual. Okay, you get a residual, and what I've done is I've plotted the residual on Y and the education on X, and you can see that for those with 16 or more years of education, they are up here with a residual of maybe 3, so 3 points on the MoCA scale, and for those who have high school education, they're down here with residual of maybe -3. So this is just showing that there's reserve operationalized in MoCA units that you can just see in the clinic. Oh, sorry, I thought that was being addressed to me. And then you can do the same thing with their functional assessment scale, their instrumental activities of daily living scale, and you can kind of see the same effect where you get sort of outsized functional impairment for a given amount of brain atrophy in the less educated individuals. Another way to look at this is with the biomarkers. I really like this study for a fairly direct demonstration of this. This was a study in which Alzheimer patients with higher or lower degrees of education were compared to controls on tau imaging parameters. So the higher educated group had 17 years of education on average. The lower educated group had 12. Both groups compared to control show the orange areas, which is the tau burden. When you compare the high to the lower educated group, you see that the higher educated group has more tau pathology. One way to interpret that is it takes more tau burden to drag them down to the same level of performance as the less educated group. And when you break it down by Brock stages, you can see that it's the high educated group that has all of the high Brock stage findings. In other words, it takes a higher Brock stage on average to bring the higher educated group to the same degree of cognitive impairment. So it's a real phenomenon. It's I'm not saying that you can manipulate this relationship once people become symptomatic with memory impairment, but through midlife, what you do apparently makes an important difference. Okay. So I'm just going to turn to some practicalities of research diagnosis and then talk a little bit about native populations. So, the difference between mild cognitive impairment and dementia, mild and major neurocognitive disorder, is a clinical distinction. You have 3 lines of evidence. You have cognitive performance as tested by some qualified person. You have someone's performance in daily living, and typically we're using an instrumental activities of daily living scale that depends on there being an informant that needs to be generated by the informant. And then you have their overall medical situation judged by a clinician. And in the research situation, the diagnosis really comes down to a consensus of experts that are bringing all this information to bear. Okay, so if you want to diagnose MCI or dementia in the research situation, it's typically done by expert consensus. If you want to go on, now this is how DSM would define a subgroup of major neurocognitive disorders having probable Alzheimer's disease. And here you'll need to lean on, for sure there's going to have to be decline in memory and learning, a period or a steady decline without periods of stability, and no indicators of other processes. So this is a sort of memory, relying on memory being salient and progressively impaired. And this is the most common presentation of Alzheimer's disease, this sort of progressive amnesic dementia, what in the past has been called dementia of Alzheimer type. But that diagnosis is wrong about 15% of the time in the best of hands, okay? And why is that? Well, progressive amnesic dementia has a differential diagnosis. There are other things that can cause it. I'll mention a couple in a minute. And then Alzheimer's disease has atypical sort of non-amnestic presentations that can also get misdiagnosed. Here's one Alzheimer's disease mimic. This is something that is getting a lot of attention just in the last year or two. But there's another proteinopathy besides tau and amyloid called TDP-43 that is associated with malfunction in the temporal lobe, including a degenerative hippocampal sclerosis, and is a cause of amyloid negative, amnestic, mild cognitive impairment, and amnestic dementia, or can co-occur with Alzheimer's disease. And this turns out to be really common. There's a paper that's about to come out that's going to say that this is, pushing 25 to 50% by age 80. Okay, so this is one thing. There's also a primary age-related tauopathy that has tau neurofibrillary tangles, but no amyloid, and only affects the hippocampus and adjacent structures and doesn't get out into the isocortex. So those are things we're wrestling with as a field. There's other things that cause amnestic dementia. Another issue, the flip side, yeah. Yeah.
Likely to be different clinical manifestations depending on the different presence of these two?
That's a good question. I'm very interested in that question. One of the things I'm thinking about is, Alzheimer's disease so characteristically attacks the inferior temporal cortex, and the part that is attacked is the part that supports semantic memory, and a great way to test semantic memory is with picture naming. So we're thinking that picture naming trouble plus amnestic MCI might push you more toward an AD diagnosis, and spared semantic function might push you more toward a hippocampal limited. That's a research question. We're going to ask that in the ACT cohort. But yeah, I think we might be able to do that. Another major issue is accuracy of the clinical diagnosis of the normal controls, because if you followed, about 20 or 25% of 70-year-olds are going to be amyloid positive, and so they're not really normal. And then this variable functional resilience is another source of variability to contend with. And it's sort of no wonder we all the time clinically see some degree of brain atrophy on the scan, and we don't know what to make of it, and neither does the radiologist, and it's always said, not excessive for age or something like that. But it's so our neurodegeneration marker is not as useful to us as we'd like it to be, because we don't know what's going on in terms of preclinical disease and resilience. Okay, these are some points that I made, and some points I think were made earlier. The true incidence and prevalence of ADRD is not really known, but it's probably higher than in white Americans, and high relative even to some other underrepresented groups. Essentially, no work has been done with these biomarkers in native populations. We don't even really know about this strong genetic risk factor for Alzheimer's disease and how it's behaving in native populations. The data are mixed on this. There's reasons to think that it's less, but I think more work is needed. There are probably differences across native groups. I'd like to know how that is getting discussed. We have high rates of medical comorbidity, and so brain comorbidity is likely to be high. And I'd say really we're talking about vascular brain injury and Alzheimer's disease, and there's going to be some issues there because the biomarkers we have for vascular brain injury aren't all that great. The protective factors of education and control of hypertension may lag majority culture. Just speculating about that. I think this would be a great opportunity to study resilience because you probably have a larger variability in the educational background than in the majority culture, for example. Norms are not established for cognitive tests, so that's a problem. There's probably cultural specific issues in the functional assessment as well. So I'd say, to sum up, really hewing to the distinction between cognitive and etiologic diagnosis is really key. It seems simple, but I see people have trouble with that all the time. There's important limits to our clinical diagnosis, both of AD and the non-AD state, which we went over just a minute ago. Preclinical Alzheimer's disease is commonplace, ultimately very important as an intervention window. For many other reasons, some of them listed there, a biomarker-based approach to Alzheimer's disease seems particularly needed for this population. The study is going to be hampered by the lack of good biomarkers for the degree of vascular brain injury. We're getting better at this, but cortical microinfarction is really hard on MR. And then I made this last point already. So those are my thoughts. I'm going to sum up there. Thank you for your attention and take some more questions. Thank you.